Right, let's move on quickly. And I hope I can persuade you to stay rather than drifting out for coffee, because there is a very critical question I'm going to ask you. How are you all feeling today? Do you feel strong? Do you feel that your life is being lengthened? I put that question to you now because that is a very critical issue we're going to address. Very different from competition and economic well-being. Will you live longer? The economy minister yesterday said that the average life expectancy now here in the kingdom is 75. In other parts of the world, it's up to 83. But what kind of lifestyle will it be? Living longer is one thing, but how strong will you be? You may have good, productive, financially rewarding life, but how good is it for you? Now, I can hear a lot of people have got other interests at the moment, but I suggest to you that this is actually rather important in terms of you working out your longevity and also your health and how well you're going to be able to work in your current job, and also the fortunes for your family and, of course, for the next generation in your country. Or are you deluding yourself about how well you are and the prospects for your strength and your length of life? Many of you were here yesterday, and you know the kind of way I'd like to operate this for the panel. It's about conversation, and I do want you to use your smartphones and tablets. Some of you may want to inject a thought or three about longevity, about your health, about the prospects for the kingdom and right around the region, but you don't want to actually tell me who you are because of the nature of the sensitivity of some of these health issues. So please use those addresses. It worked tremendously well yesterday in the sessions that I was chairing. Make this a conversation, and I want this to be engaging for you because it actually affects you, it affects your family, it affects your prospects, it affects your health, and it probably affects and will factor into the kind of judgments you've got to make about your life in the future. Share your concerns with me, share your concerns with the panel. And before the panel come up here on the platform, let me introduce the Vice Minister of Health, His Excellency Dr. Mohamed Kushem, who will set the scene, and then I'll be joined by four more on the panel to hear your thoughts as you listen to the Vice Minister. Get those thoughts coming to me, and I'll be standing down there as I was yesterday. The floor now for the Vice Minister of Health.
Good morning. It is indeed a pleasure and a privilege to be joining you today. And over the next 8 to 10 minutes, I will be sharing with you what is happening now and what will be happening in the next 5 years in the health sector. And the health sector today is undergoing a major transformation, not only in the Ministry of Health, but in the other government sectors and in the private sectors too. And we see some of the global trends that is coming our way in terms of the increasing demands on health because of the growing population, longer life expectancy, the aging of the population that we're witnessing, coming with the chronic diseases and disabilities that goes with it. And then, of course, the rapid advancement in medicine that we are seeing every day because of the R&D and the involving technology. And medicine is becoming a very complicated business. Actually, it's becoming a risky business because everything now is based on evidence. And the whole world now is focusing on prevention of these diseases because we see so many things that are related to the lifestyle that is happening today, and we will share with you some of it in a few minutes. This comes, of course, with the increasing price tag attached to it, the spread of the non-communicable diseases like obesity, hypertension, diabetes, and the morbidities and mortalities that goes with it. And now medicine is becoming also very personalized, as we see in decoding the genome and other things. And this slide shows you how the whole world now is suffering from the increasing healthcare costs. Not only in Saudi Arabia, we see it in Japan, United Kingdom, Sweden, and United States. And in the kingdom, we have our own challenges. We see it in the population growth, in the high number of chronic disease burden. We're seeing it in the aging population, because today we have about 1.1 million people over the age of 60, and in another 5 years it will be 2.2 people over the age of 60. And of course we have the sedentary lifestyle that is happening right now, together with the increasing demand and the road traffic accidents, and I'll share with you some of the facts. Smoking today is another challenge by itself, and today it's at about 24% of the population are smokers. And diabetes and obesity, of course. Obesity today is numbers that are not very proud of, but we take a very high percentage of the population that are obese. And so in the Ministry of Health, we have adopted a strategy over the last 5 years that goes over another 5 years from today, and talks about 5 pillars. Number 1 is the delivery of care, and we intend, of course, to implement the integrated healthcare plan, which means that we will be moving from the primary healthcare system, and the patient will be moved in a organized fashion from the primary healthcare centers to the general hospital, to the specialized centers, and to the medical cities around the country. And today we have 231 institutes that we are building, 143 hospitals. We're building a national lab together with other dental centers, diabetes centers, and labs everywhere. The total of 231 institutions that we are building right now. And the number of beds that are expected over the next 5 years, today in the Ministry of Health has 38,970 beds. It will go in 5 years to 73,768. And the number of hospitals will also be moving from 272 right now to 357 in 5 years. The number of physicians, when it comes to capabilities, expected to rise also from 32,000 to 73,000 in 5 years. Number of nurses from 64,000 to 194 nurses. And of course, governance, we are now looking for the quality in care and GCI accreditation and all what goes with it in terms of monitoring. And when it comes to IT, we are looking for a unified HIS in all over the hospitals, together with an electronic medical record, with a robust referral system, and the telemedicine. And finally, it's the finance and the cost. And this is the dilemma that we are trying to look at, because we know it will be hitting us over the next 5 to 10 years to come, because exactly how we look at cost containment and with a good health coverage, and of course what are we to do with the health insurance schemes that is good for us, together with the public-private partnership that should take place. And so today, in the whole kingdom, we have 38,000 beds, 970 in the Ministry of Health. We have 12,000 125 in the other government sectors like the National Guard and the Ministry of Defense and the universities, and the private sector at 13,881 beds, and that makes a total of 64,976 beds all over the kingdom. And this shows you here how the expansion that will be also happening not only in the Ministry of Health, but in the other government sectors and in the private sector, where we expect the private sector to grow by 6,000 beds, the other government sectors by 14,000 beds, and of course, as I mentioned, the Ministry of Health by 35,000 beds, the total of 120,000 beds in 5 years. And so the healthcare sector is going or undergoing a major transformation, major expansions, and we think that when it comes to investment, we can look in these 5 areas: health financing, pharmaceutical industry, health education, e-health, and the medical devices. And the ministry always, of course, welcomes and look for the public-private partnership with the objectives that goes with it in terms of supporting our national healthcare objectives and serving the broader health concept. We need a system that is profitable and financially sustainable, and a partnership that will bring capabilities and technology to the country and enhance national security in terms of the strategic drugs and so on, and ensure our self-sufficiency and increased number of Saudis, of course, in the healthcare industry. And so our partners today in the healthcare industry, of course, are the regulators, and that's SAGIA, Mudun, Saudi FDA, ECA, and NICDB. And the payers, of course, the Ministry of Finance and the SIDF, and the researchers, we have King Abdulaziz City and KAUST. And so healthcare investments in the kingdom, I think we have the competitive advantage in the country because we have a stable and sizable economy. We have an effective and well-respected regulatory agencies. We have access to financial incentives for foreign investors, the large investments in the research and development sectors, and the abundance of upcoming medical schools and colleges. And so in summary, the healthcare sector in Saudi Arabia is undergoing a major expansion and reform. We have the challenges of cost, the non-communicable diseases, diabetes, hypertension, and so on. We have the problem of our lifestyle and the population growth. The major investment opportunities in health areas we think should be related to training and education, R&D, engineering and construction, e-health, pharmaceuticals and medical devices, and biogenetics. Thank you.
Vice Minister, thank you very much indeed. Can I invite you to come and sit down here? And the other 4 panelists are going to join us on the platform to build on many of those alerts that we've heard from the Minister. They are not alerts unique to Saudi Arabia. You hear it in so many of the developed and developing countries now, but they are very specific in terms of the potential costs for an economy and the capability it will have to limit the ability of manpower at every level to function efficiently if there are these major healthcare challenges. Now, please do keep looking at that address, and please do, particularly if your company or your institution is facing serious challenges with the health of your colleagues in your labor force, and also the kind of concerns you have about the cost that will be involved in maintaining good health. And how many of you want to live longer? How many of you want to stay healthy? Well, of course, you all want to live longer and stay healthy. The question is about the condition and the nature and the quality of that extension of your lives in the current way of thinking and calibrating the future of any country. Now, let me ask all the guests that we have on the platform. I want to ask them, and I gave them notice of this right at the beginning, a simple, very sharp question before I get an idea of their solutions. And I'm going to introduce them each as I ask them for their comments about how serious a problem this really is. And we've heard from the Vice Minister about the costs and about lifestyle. And I first of all want to go to James Nakagawa, who is Chief Executive and Chief Care Architect of Mobile Healthcare. Welcome. Now, he though has a story which I want him to share with you about his own health tribulations, because you probably all feel you're pretty well and fit, even if you don't maybe get enough sleep and maybe you eat a little bit too much. But James has a salutary story about what can hit you at any point, the cost, the emotional costs and the physical costs for you personally when this happens. James, in about 3 minutes, just tell us what happened to you and why we need to take this very seriously.
Thank you. After the last GCF, everything was going well. 3 months later, I tipped back in and became a type 2 diabetic. Within 24 hours of tipping in, I had an emergency triple bypass operation and almost died. 1 week later, I was supposed to go on a business trip to the Middle East, and they said if I would have gotten on that flight, I would have died mid-flight or when I arrived. It was unstable angina attacks. And it really shook me up, where it impacted my whole lifestyle, my whole view and everything, our whole mission for the last 10 years, where how do we change our lifestyle? As you may have recalled or maybe seen some previous videos, I lost 25 kilos. And within the last 18 months, I've reduced my HbA1c hemoglobin month on month below 4.9% from an original 9.7%. I almost tipped out of all my blood vitals. It's in the lower range of normal. And how to achieve that was extremely difficult. I mean, I think anyone who tells you that there's a magic pill or a magic pharmaceutical drug or an infomercial or buy this, buy that, and be a couch potato and you can get magic abs, they're lying to you. It's just a lie. And I really wanted to communicate that message and share with you today my story.
James, what should you have done in retrospect which could have prevented that?
Thank you. I think lifestyle. Again, I was smoking. I didn't smoke cigarettes, but I smoked cigars on a daily basis with an excuse that it controls stress. I ate whatever I wanted, drank whatever I wanted. You know, when you have business dealings, business lunches, dinners, entertainment, travel, it's so easy. And my mantra now is, just because you can doesn't mean you should. Eat less, but eat the best.
And when you hear what the minister said about the challenges here in Saudi, again with the cost, the lifestyle cost, the lengthening age span, and therefore the additional costs which are now accumulating, again, what would your message be?
Prevention and wellness raises the quality of life. I don't think you can just look at longevity data, but more importantly, the quality of life as you develop these polychronic diseases. It slows us all down and it will hit you. Because also, although I was born and raised in Toronto, I'm Asian-bodied, and Arab-bodied people as well are more genetically prone to developing chronic diseases. So with that, we have to be more careful than our Caucasian friends and colleagues just because of genetics.
Right. You feel you now have a stable lifestyle as a result of
Yes.
what you've been through, and you're lucky to be alive.
Oh, every day is a gift.
Right, asking James to share with you his story because it could have, in fact, happened to any of us. Let's hope it doesn't. And we need to be aware of this because it shows how fragile, in many ways, what we think is a very resilient lifestyle is. Let me go to Bobby Robbins because you're running the Texas Medical Center. You're president and CEO there. As you said to me, it's your first time in the kingdom. But you also have done an enormous amount on cardiovascular. Now, again, I'm asking for the medical side of this and the challenge to build on what we've heard from the Vice Minister here about how profound this challenge is, not least changing lifestyle and attitudes.
Well, thank you for that wonderful story and sharing with us, James. I think James's story is illustrative of the problem. All of our systems, whether it's the U.S. or Asia or here in the kingdom, we're in a reactive sick care. I wouldn't call it health care mode. We're in a sick care mode. We need to change that paradigm to a wellness care mode. And so what could James have done? Well, first of all, he correctly pointed out your genetics are important. He could have chosen his parents better, but he didn't have a choice in that, right? None of us do. So with all biology, it's an interaction of your genetic makeup and your environmental factors. So that's where we need to focus our attention. I was touring with one of my former trainees yesterday from trained with me in cardiac surgery at Stanford University at Abdullah Aziz National Guard Hospital, not far from right here. And there was a great poster on the wall that talked about all of the factors that James mentioned in his daily life: smoking, exercise, what you eat, how you manage your stress, knowing what your numbers are, your blood pressure, your cholesterol. All of those things are important. Don't wait till you have to come see someone like me. And the most impressive thing James could have done was to stand up and pull his shirt open so you can see that he has a scar about a foot long in his chest. You don't want to have that happen. You don't want your employees or your family members to have that happen, because it decreases productivity, it decreases the quality of life, which is what we're talking about. So the message really is about prevention. And prevention means changing lifestyle and seeing your doctor and be proactive, and don't wait until you have to have heart surgery.
That's great, because I want to move on to that specifically, because in the next 30 minutes, when this session ends, I want people here to know what they should be doing and thinking about for living longer and staying stronger. But again, the scale of it as well. Mitch Higashi, Chief Economist of GE Healthcare. As you look around the world everywhere, including in this region, what are you seeing quickly?
Yeah, so thank you. It's a great honor to be here. What we are seeing is that the world spends about $12 trillion on healthcare globally, okay? And that number is growing at about 5.5% per year. 80% of that cost is directed at about 20% of the population, including the Kingdom of Saudi, and a great deal of it is directed at what His Excellency Dr. Koshaim refers to as non-communicable diseases. So this would be diseases of metabolic syndrome, so obesity, cardiovascular disease, diabetes. This is putting a terrible strain on the future competitiveness for the region and also for these advanced economies. What I would say is there's big promise in big data, and big data as a predictive tool to forecast the future burden of disease. So for example, what will be the future pattern of disease that the kingdom will experience 10 years, 20 years from now? How can they develop and tailor better preventative programs so they can target people like James earlier and in advance? And what kind of healthcare system needs to be designed for that future state? And the Saudi Ministry of Health is becoming a thought leader in using big data to forecast future population health trends as a powerful predictive tool. And this is really the big promise of big data. So 2 months ago, at the World Health Organization in Geneva, the Saudi Ministry of Health presented groundbreaking data, basically taking advanced analytic techniques and applying them to population health and mapping disease patterns and visualizing it for the entire kingdom. And this quickly became the talk of the conference. And so I think the kingdom has enormous potential here to become thought leaders in this emerging field of population health forecasting, not only for the region, but potentially globally.
Let me just reiterate what Bobby Robbins said. You've got to be, you must no longer be in a reactive mode, you've got to be in a wellness mode. Let's keep that at the back of our minds for the next half hour, and please send me messages. I can't believe all of you are complacent about your own health situation and the challenges you face in your company, your ministry, or wherever you're working. These are very, very serious issues, and that's why we're discussing it today. Let me move on again to get an idea of the scale and how you're seeing it. Crispin Ellenson, who's partner of Olive Wyman, the Global Strategy Consultancy, you spent a lot of your time in this region. How are you seeing this developing? Anything you can add to what we've heard already from the panel and the Minister?
Yeah, I think globally, all health systems are facing this real, what I call a trilemma. How do we manage cost? How do we manage quality? And how do we improve patient experience? You know, at the moment, typically, we're spending almost half our health budgets on the sickest of the sick, 5%. So in the UK, that's $75 billion a year spent on 5% of the population. And tell you what, we give them really bad treatment. They're treated shockingly. And that's before you add the problems of increasing longevity and more of these polychronic conditions. So for me, there's something about we need to look at the care models we have in order to free up the capacity and the money to start tackling prevention. At the moment, we can barely manage, or even we can't manage, just to deal with the sick. Never mind find the funds for prevention. And that means turning the way we do health on its head. At the moment, you know, I liken health to the Soviet retail system. You go to a shop and they tell you, they know what you want, they know how you're going to buy it. We need to turn that on its head, make it patient-centric, and by doing that, we can start to tackle this trilemma.
Well, let me pick up on that, because this is a central core to, I think, what all of you want to talk about how you turn the way money's being spent now into something far more effective, which helps another 20, 30, 40% who are likely to become affected by this as their lives get longer. All of you, what's your view of what we've just heard from Crispin, James, particularly the way the balance has to be maintained and created now to not just worry about care, but redistribute resources into prevention?
Right. As Dr. Robbins said, the transition from sick care to prevention, I think one of the biggest challenges is the mindset. Traditionally, medicine, people on the front lines view prevention and wellness, let them manage on their own. They should be doing that, and if they don't, they're lazy. It's kind of an either-or situation, and I think that has to fundamentally change.
But all of you, again, how do you do that? You literally have television, online counseling, which says, don't eat fatty stuff, eat fruit only.
So I think that's an important point. And so as we map the human genome and understand our genomics, the one gene we're all looking for is the compliance gene, right? Why don't we do what we should do? Because we're human. And I think the key is going to be, it was pointed out earlier, we need to move away from these big, expensive heart operations and move some of the resources out into not only primary care and prevention, but even into the homes. As I was touring the hospital yesterday, I was very impressed to see that there was a clinic that talked about lifestyle changes. Once you have a foot-long scar on your heart, that gets your attention, and you're more apt right then to change your lifestyle. So focusing on having programs that go into the home and having sort of a life coach or a muse to educate you and keep you doing the things that you need to do. Moreover, I think that as social networks develop, there's a lot of opportunity there as your peers and the people you choose to hang out with, as you all try to understand the risk of and dangers of cancer, cardiovascular disease, neurological diseases, I think that we'll start to get the message across. For instance, 30 years ago when in the U.S., not many people use seat belts. Almost nobody would get into a car today without a seat belt. That's a major shift in one generation, and I think smoking is another thing, eating the right foods, dealing with stress, all the things we know how to do, but it's education and really enforcing and rewarding people and incentivizing them to do that, make these changes. And that's what's going to happen in the U.S. There's going to be more empowerment of the patient, as Chris was saying about patient-centric care. I think that's a key question that we're all grappling with. So I think empowering the patient, educating them, and incentivizing them economically is going to be a key also.
But let me put it to you, and this is a time bomb. It's a health time bomb. You've experienced yourself personally. You didn't expect it to happen, whether it be in Saudi Arabia or right around the country in China and elsewhere. We're seeing the enormous level of obesity and diabetes, and so it comes down to as much the diet. How do you persuade people? It's all very well having intensive kind of one-to-one visits in homes, but actually that's very, very costly. What about just changing the way in which people think about food, think about what they're offered, and saying no?
Yeah, and so I'd like to add to Dr. Robertson's comments, and really this is ultimately a cost containment issue that His Excellency Dr. Cushing talked about. GE is a large employer. In the United States, we have over 130,000 employees. There's two things that we did, Nick. The first thing, it's all about what we call nudging, making it easier for people to make healthy choices. When we looked at the cafeteria, this is the employee cafeteria for 130,000 employees. The cost of a salad is more than the cost of a hamburger, okay? So immediately what we had to do was incentivize, make the salads cheaper. We subsidized the cost of salad. That's what we did in the cafeteria. The fitness club membership, we had great on-site healthcare fitness facilities for all of our employees, but they had to pay a membership fee that was about the same as going to a regular gym. We made that free. Okay, so we're not at a point now, we're measuring and tracking these healthcare costs. We are not at a point yet where we can say costs have gone down, but the growth in costs are starting to plateau.
And what's been the impact on the incidence of absence because of health problems?
Productivity goes up, absenteeism goes down.
And the effect, do you actually have metrics on weight and body mass and everything else for your employees?
We don't track the employees at that level. I think the key to understand, we have partnered with and looked at other large employers in the United States. You have to recognize that what we observed, there's about 5 different types of employees, okay, ranging from the worried well to people who really don't care and aren't going to get motivated to engage in health, and they're very difficult to reach. But you want to get as many as you can to engage in healthy behavior.
Let me encourage all of you to debate among yourselves almost this issue of changing the model of how money is used, which Crispin has raised, and all of you, I think, in your own way have raised, how urgent that is and how much that requires, that significant change of mindset, which I think you talked about. Crispin, again, I mean, I'm struck, essentially, the danger, the threat is complacency, complacency, complacency. Crispin.
We've talked about incentivizing individuals, patients, consumers, if you like. But we also need to look at how we incentivize doctors. At the moment, in this provider-driven system that almost all countries have, doctors are rewarded for doing things, for interventions. So surprise, surprise, they want more interventions. So they do more reactive stuff, they do more unnecessary stuff. What we need to do is to shift to a system where we're rewarding them for prevention. Things like the Accountable Care Organization, where you pay a doctor to look after the overall health care of a population, and if they go into hospital, he has to pay that out of those costs. That starts to drive the prevention side. And as part of that, I just reiterate the need to shift from always everyone wanting to go to hospital. Let's get care for these chronic conditions out of the hospitals, into the community, into the homes. Now that's really difficult, but that's the way we need to go if we're going to make something that meets the patient need.
James, Bobby, your comments on that?
Yeah, I was going to just say that. I think everyone in this room who works in healthcare or who's attending the GCF is in the 0.1% of the population who have the power, the privilege, and more the incentive to change. And how to get rid of this complacency is to personalize it. And let me just share with you, when I was in ICU, flat on my back, maybe it was the drugs or hallucinating, I'm not sure, but one thought kept occurring to me, and it was to really think about your children and your future grandchildren. And let me give an example. These chronic diseases are lifestyle related, meaning they're largely preventable. And that includes a great majority of cancers as well. So at some point, if your child or your grandson asks you, Grandpa, why couldn't you save me? Why couldn't you prevent me from developing this? What will you say to him? How will you answer that? And I think when you think about that, the power is within you to change now, to actively engage and promote public-private partnerships, academic collaborations, large private partnerships, but to do it now because health outcomes worldwide are not getting better, they're getting worse.
Yeah, I want to just follow up on that. We're now entering a situation in time where our children and our grandchildren will not live as long as we do.
Will not.
Will not. Because of all of the issues of childhood obesity and all of the inactivity and things. So think about that. We're living longer than our parents and our grandparents, but we're now on the verge of a threat that our children and our children's children will not live as long as we do. That's a real threat, and there's data to support that. I just wanted to follow on to I think Chris had it right about this value-added proposition of delivering the highest quality care at the lowest cost with the best customer service. You do that in your businesses every day, but healthcare has never been treated like a regular business. As a heart surgeon, I was paid to do big, important operations like heart transplants and big bypass and valve operations. Nobody ever paid me based on my outcomes. What other businesses there like that, right? So it's going to be a shift toward quality, even for the Minister of Health, who has to allocate funds to certain institutions. Now there will be a hard look at this value proposition of what is the quality outcomes. And I can tell you yesterday when I was at the National Guard Hospital, they're very, very focused on quality because they know that they can do more and it's the morally and ethically right thing to do for their patients. But it will also drive down costs. The higher quality you deliver, the lower the cost. And even in a fee-for-service system that's going to shift to where you're going to be paid based on your outcomes and how much it costs you to deliver those outcomes, the same in the publicly funded sector, allocation of funds are going to be driven by quality.
Vice Minister, what's your reflection listening to this kind of observation of the global challenge? It's not unique to Saudi Arabia. You've put up a lot of metrics and a lot of data of how you see things at the moment, but you did emphasize lifestyle and the cost. What are the implications, therefore, of the kind of radical suggestions we're beginning to hear from the panel?
I enjoyed very much the discussion here. Look, there is no magic solution here. It's we have to reduce the burden of disease. To do that, it means that you have to discover, take any cancer now, let's say breast cancer. We know for a fact that a woman that has a breast cancer size of 1 centimeter and less has much greater survival than the patient discovered with a mass of 4 centimeters in size. And when you discover a mass that is less than 1 centimeter size, there will be no chemotherapy, no radiation. It's a small procedure. So the cost is very much less. It's not only the survival time. And when you discover a mass in the breast 4 centimeters and bigger, this means chemo, means radiation, means longer time in hospital, bigger operation, and so on. And with that goes the cost. So that's what we need to tell people. Discover the disease early, what we call early discovery of disease. Now, take diabetics, for example. Out of every 10 diabetics, there are the group that what we call the pre-diabetics. So if you're not diabetic today, by doing a simple test, we know that you will be a diabetic next year or the year after. And so these people that are pre-diabetics need now to look at their health, examine the way they do things, and then reduce their weight, stop smoking, and start practicing exercise.
But this shift, particularly after the data that Crispin gave us about 5% taking 50% of the resources, that the fact that that's in many ways a very inefficient use of the resource you have available, shifting significantly the mindset and the understanding of prevention, and particularly after what we've just heard about people actually not going to. I thought we were all going to live to 120, Bobby. But
think about that. Think about what your children do. They sit, they do video games, they're texting.
Yep.
They don't even, I mean, James and I don't even have a conversation. We just text with each other. We sit right beside each other.
So
no
this is unusual. You're talking to each other.
Yes.
Okay.
Yeah. And not as much exercise. It used to be that you had to walk a lot and you did manual labor and you had better food. This is a real problem.
But Minister, as a member of a government, do you see the potential in this kingdom to actually move in the kind of direction we've been hearing here, where here in the kingdom there tends to be an assumption that there'll always be a great health system if you have a problem?
And that's what the message we want to now to tell people is that we cannot continue in this same way. We see a problem coming. If we continue in the way we're doing things right now, the healthcare cost is coming up and up, and we see that yearly. And the fact that we have an aging population coming, together, of course, with the equation that was cited here a little while ago, that the aging population is the one that is actually consuming all the cost.
Right. That's an important statement. We cannot continue in this way. Let's pick up on some of the points that some of you are raising, and please keep those messages coming. I can see hands going up. Get the microphones here at the front and at the back, but I want to pick up 2 points already. One from Amr Salem. Lots of talk about the right food. What are we doing to regulate food production companies to make sure they provide real, right food? And into that, of course, you have to inject the issue of advertising and brand promotion, all of you. I mean, what's the answer?
Yeah, I think there's a great book. There was just an author who wrote Salt, Fat, Sugar. Salt, Fat, Sugar. And he was just in Houston giving a talk about that and how the food industry does need to be held accountable. And in his book, he develops the idea that the food companies, the reason we like that is because they know it tastes good. And we eat what tastes good to us. So there is some scrutiny being put upon the food producers. But the real question, I went to a beautiful buffet last night where there were a lot of fruits and a lot of vegetables. Those are the things that we need to be eating,
and
not processed foods.
What did you eat?
I had almost all vegetables and fruits, and it was beautiful. I mean, you've got beautiful food here to eat. But the issue is that the fast food is what tastes the best. And so I have to admit, I do love cheeseburgers.
Quickly, let's go through a lot of questions here in the last 15 minutes. Regulating food production companies. James, Crispin, any of you?
I mean, whether you regulate them or not is a sort of political, ethical issue. But we have these two huge challenges. You know, how do we incentivize individuals to look after their own health? And how do we incentivize docs to actually move into prevention? And it's really difficult doing that when half the messaging coming out is in the opposite direction.
Mitch, James.
Yes, I'm not in favor of regulations. I believe that all foods are perfectly fine, including fast foods. You know, so for example, at lunch, if I'm going to have, not promoting McDonald's, but if I'm going to have a Big Mac set, well, for dinner, I'm not going to have a Wagyu steak. I might have a vegetarian dinner or the fish to go with it. So knowing the nutritional food composition, knowing the data that goes into McDonald's or any food or any meals, I think is crucially important.
Is there anyone from a fast food business here who'd like to say something? I'll give you your right of reply here, or any food production company. Please make yourself known. Mitch,
Yeah,
you want,
yeah, go ahead.
Just very quickly, labeling on food and making it not more expensive to make healthy choices.
Bobby.
Right.
Yeah, I was just going to follow on to one of Mitch's comments about big data. I think that more patient-centric health is going to mean, and I think he's right, it's all going to be about as we all get our genome measured and part of our health record, empowering the patient to own that record, make it portable. I believe that we'll be carrying on our iPhone our entire patient record. It'll be portable. It'll be accessed through the cloud. There was a company that was just announced recently at JP Morgan conference called Nant Health, which is connecting electronic medical records through the clouds and empowering the patient to have that data, not be owned by the hospital, and make the patients more accountable. And I would say that people know more about their automobiles than they do their own body and health. Empower them, give them the data, and get them choices.
Will it be like an aircraft boarding pass where you check in, you actually book the seat, and you tell them what kind of
Absolutely.
class? All right. Quickly, because there are a lot of people out there. And
Very
I've got
quick
10
one,
minutes.
an interesting model that they're experimenting with in the US is where Walmart are taking on, the big retail store, is taking on the provision of some primary health care. So you go to see the doc, if you like, whilst you go shopping. Now the interesting thing is Walmart know what you buy, and they can give you bonus points, credits, price reductions if you start buying the right sort of food. So there are different models integrating healthcare with different industries in novel ways, which can start to address some of these challenges.
Can I just put a point? I know 3 or 4 of you want to come in again, but an email from Andrew Shaw here. What evidence is there, picking up Mitchell on what you said, what evidence is there to show the economic payback for a company to invest in wellness and prevention for its employees? Is that clear?
I think it's very clear for us. So we look at different categories of health, right? So clusters of what we call non-communicable diseases or comorbidities are very expensive employees, right? And healthy employees are not expensive. And this is a productivity gain for the firm. I mean, this is good business sense to foster.
Do you all agree on that?
I would absolutely agree, and there's plenty of data to support this.
All right, let's go. Microphone 4. I'm not going to get stressed about this, but please introduce yourself.
Charles Savage, Munich, Germany. Could we be asking another question? As you remember, Harvey discovered the circulation of blood in the human body in 1628. Bernard Mandeville, trained in medicine in Leiden, came to the UK and asked, what is the circulation of blood in the body politic? In this, in 1707, in his Fable of the Bees, and please look at it, he talked about the doctor being more concerned about his wealth and fame than the patient's health. It's lucky it's changed. He said that if you want an abundant society, you have to accept and welcome greed and corruption. Do we have an obese society with not just salt and sugar, but carbon? And is our real societal sickness greed?
All right, is our real societal sickness greed?
I think it's not so much greed, but it's that it's easier to be unhealthy than it is to be healthy. I think James hit it right on the head early on. Before, when we were children, you ran around, you played, you didn't have all these foods, you didn't have the electronics, you didn't sit around. So in my generation, this has all changed. I'm not maybe greed on the part of the companies that are making money off of all these things, but that's just the way life goes. It comes back to individual accountability, and that's where I think education and engaging people individually and as populations is going to be the answer.
Anything more to add? Minister.
We are eating more than what we need.
But how do you tell people?
Children are eating more than they need.
Yes.
So how do you persuade people, particularly the next generation, not to do that?
I think it's probably education here. People do not realize how serious is this.
Should it be appearing as an app on a smartphone?
Well,
tablet?
that's going to be an issue because you've got all these biometric things. So it'll tell you how many calories you eat. It'll tell you how much fat, how many carbohydrates, how many steps you took, how much sleep you got, how much REM sleep you got. All of these things are going to be going to the cloud and be part of your medical record that you're going to own and you're going to be accountable.
But then you
for.
feel stressed by what you've read.
No, it gives you data by which you read. If everybody here knew how much they ate and they thought, I can't believe I'm eating 3,000 to 5,000 calories a day. That's what Olympic athletes eat. We need to be eating 2,000.
Mitch?
What Dr. Robbins is describing perfectly sums up the intersection between big data and health. I think there's an enormous opportunity here for the kingdom. Why is that? Because all this big data is messy. Okay, big data means volumes of data, massive amounts that are now available to us from a variety of sources, right, including smartphones. We've had amazing advances, cloud computing, advanced analytics, to enable this abundant supply, but it needs to be refined. Okay, so we need a new generation of data scientists who can refine this big data, okay, package it, give it form and function, add standards, and all of that will make it easier for people to engage and understand all of this data that's being generated about themselves and how to interact with the healthcare system.
Minister, picking up on the point I put to you a couple of minutes ago, there's a note here via email from Dubai 1971. Why isn't the subject of health included in the curriculum so children become educated about healthy living?
That would be one thing to do. Definitely, because 30 years ago, we didn't see this. Today, out of every 30 students in a class, at least 10 will be overweight. Just go back 30 years ago, in this country, it used to be only one out of 30. So what's happening? We're eating more than what we need.
Okay, lady here. Number 5, please.
Good afternoon. My name is Yasmin Al-Tuwajri. I'm a senior scientist and epidemiologist at King Faisal Specialist Hospital. In the beginning, I'd like to acknowledge the marvelous effort that the Ministry of Health has done recently in an effort to revitalize our healthcare system. And I should mention that I'm a grateful recipient of one of their research grants for a project that we're doing on the National Health and Stress Survey.
Could I get a question from you, please?
Yes.
Time is short.
Yes. So, the mental health is a growing epidemic that few countries are paying attention to. So that's a very important point. The Saudi Arabia population is very young. They're currently all healthy, mostly healthy, but several decades from now, we'll be seeing the effect of this modern, unhealthy lifestyle.
We've just heard that from the minister, yes.
And the solution is multi-sectoral. I see there's a need.
Could I have a question, please?
Is it possible to establish a task force which includes members from Ministry of Education, Ministry of Health, Ministry of City Planning, and so on?
Is there a task force, Minister, for this? Because of if you like, it could become a national catastrophe. That's probably overstating it at the moment, but it could become something which is existential for your next generation.
And we have the numbers to show people in terms of the increasing number of heart surgeries and the number of cath that we're doing. The question, of course, is that it's not only the Ministry of Health that can do this alone. We are talking for other ministries in terms of the role of TV, radios, all communication facilities here needs to
Right.
be engaged in this.
I'm pushing the time a little bit, but let me just hear 2 more points, please, from here and from that gentleman there. And there's also a lady over there, but please be 30 seconds only, otherwise I'll be moved off at high speed.
Hi, my name is Abdullah Taha. I'm General Manager of Balsam United. And I have a question to the Vice Minister. It's on the point of James. We here represent maybe 1% of the population who enjoys the good lifestyle of jogging, go to the gym. They can enhance their lifestyle this way. What is the government doing in the prevention and control of non-communicable diseases in less fortunate communities and villages and towns and the likes of the slums and these where they have no access to even good health practices and habits.
The challenge of communicable disease. Just hold that for one moment, Minister. The lady further back, please, who has the microphone. The lady, please. 5.
Thank you. Assalamu alaikum. My name is Hannah Al-Mahid. I'm a bioinformatics graduate. My question, and a Marshall McLennan Associate Director. My question is addressed to the Ministry of Health Vice Minister, Dr. Mohammed Al-Khashem. With regards to the mobile satellite centers program that have been implemented in various regions in KSA, these are specifically to assess and ensure clinical healthcare quality, outpatient, ER, and quality of services. Do we have, or is there a studied direction of replicating an identical pattern with future programs to include both surgical and inpatient quality care along both private and public healthcare centers? Any timelines, any directions would be great.
All right.
If you can elaborate.
Minister, bear that in mind. And the final question here, please. The gentleman at the front, please.
My name is Talat Dhafir, Vice President of SABIC. I am really hearing two things today from Dr. Robinson and from what we heard yesterday. From Dr. Robinson said that our children will not maybe live as longer as we did. And this is, it seems to be, it's a cycle, while we heard yesterday as well that the life expectation in Saudi Arabia is moved to 75 years of old. So now this will take the question, direct question, say that what are we preparation? What is our preparation in Saudi Arabia? And we take maybe, because it's, as I said, it's cycle, as an experience from another country, what we prepare for. Do we invest in medical care in hospital or in a cure or in prevention, which is maybe something to do with the food and everything?
All right, I think there are explicit answers to much of this. I'm going to have to call it to a halt in a moment, but communicable diseases and that other more technical question. Quickly, Minister.
Look, quickly. School health. We have to start with school health. And so this will be very effective, and we know it works. We have to go to the schools, and now that the Ministry of Health is responsible for school health, we have a plan to go to the schools with this message. That's number one. Number two, we need the municipalities and other agencies to make sure that we have open space for people to practice walking and then enjoy exercise, and then reduce salt in the food. We know that decreasing salt is important. Of course, it's not the Ministry of Health that should do this. It's other ministries here.
Sure.
And so that's
other question
three
there.
important things that can be done. And then the walk-in clinics, the primary healthcare centers everywhere means that people can go in and check their blood pressure, check their sugars, and so on. That's something that is also important to discover the pre-diabetics and hypertensives and so on.
And that lady over there.
I am not sure that I got the point.
All right, maybe you could connect up afterwards with that particular technical question. I think we've answered a lot of the point you raised from the front here. I've got to bring this to an end, although I think there's a lot more steam in this issue. I do hope that if this conference takes place this time next year, that I'll see you all here. You will be living longer and staying healthy. But James, perhaps you could tell us what you eat these days to ensure that everyone here knows what is necessary to prevent what you went through and to ensure that you're still here.
Well, I'm a big believer now in eating salads. I eat salads with no dressing 3 times a day with every meal. Breakfast, fruits. I don't drink fruit juice. I eat the fruits. And surprisingly, after the first month, it really invigorates you, gives me more energy during the day. And I work 6-7 days a week, 16, 20 hours a day. And this type of healthy breakfast, or just eating non-packaged, non-processed foods and just being a little bit more careful, really changes you.
And Bobby Robbins, is that the kind of person who you would not see as a cardiovascular case in Texas?
Well, if he'd started doing it when he was a child, and my point about the potential of our children not living as long as we are unless we radically change, because we grew up in a time when we didn't have McDonald's and other things. They're growing up with it from birth. So it's a cautionary tale that unless we change and do a lot of the things we're talking about today, then we're going to pass this burden on to our children.
We've highlighted for you an immense legacy, not just for Saudi Arabia, and a real challenge for so many countries in both the developing and developed world. Not unique to this country, not unique to this panel, but we've certainly highlighted, and I hope you go out and have glasses of water rather than coffee and big cakes. I can tell you that the coffee break or water break is 10 minutes. The next session is in B, but can I thank the Vice Minister and our four panelists for really getting to the heart of this issue.